Today we'll be talking a little bit about genetic prion disease. We'll review some of the basic information about genetics, review some of the genetic prion diseases, and then also some specific issues related to genetic prion disease. So our genetic information is inherited from our parents. We get half of it from our mother and half of it from our father. And we inherit it in the form of chromosomes. And we have 23 pairs of chromosomes. One pair determine whether or not we're male and female. And then the 22 other pair do other functions. And again, we inherit one set or one half from our mom, one half from our dad. And those chromosomes that you see outlined in the kind of neon colors are really wrapped DNA around those rods very, very tightly. And for the purposes of this talk, we care most about chromosome 20 because that's where the prion protein gene resides, PRNP. And all genetic prion diseases are caused by genetic mutations in that gene. DNA is the basic blueprint of life. And then basically that is then translated into RNA, which is the messenger. It takes that genetic information outside of the nucleus of the cell, and it tells it what proteins to make. And proteins are very important. Proteins make up the structure of our cells, of our organs, of our body, and they also determine the functioning of our bodily processes as well. So essentially, human life and any animal life is comprised of proteins. So what's important to know about DNA and RNA is that basically those rungs on this ladder, so to speak, are only comprised of 4 different chemicals, what we call nucleotides or bases. And it's basically an alphabet of genetic information. And those are the letters. And those letters come together and are read in words of 3-letter pairs. So AUG is read together, ACG is read together, and those 3-letter combinations make amino acids. Amino acids are then strung together and they make a protein. So if we were going to use a literary analogy to this, your nucleotides or bases are your letters. They form words in the forms of amino acids, and then those words make up a paragraph or the protein. So what happens with genetic mutations? So if this is our original code, and we have a mutation in the very middle where that C is changed to a U, what will happen is that different amino acids will be produced. So before you had amino acid 1, then amino acid 2, and amino acid 3. But after the change, you would have amino acid 1, and then amino acid 3. So you would have a different sequence of amino acids. Now, sometimes that's enough to completely disrupt the protein. The protein no longer functions, or actually has what we call a gain of function. It causes toxicity. But sometimes that alteration, even though there's a change in amino acid, the protein still functions, but it changes the way that it's shaped or the way that it's folded. And that's very pertinent to our illness, prion disease. Because in prion disease, we all make normal prion protein. That's the 3-dimensional structure on the left. You can see the way that it's folded on each other. And the fold is basically determined by interactions between amino acids, much like if you had 2 magnets together, the way they repulse or attract one another. But in prion disease, it's characterized by the disease-causing prion protein, which is shaped very differently. Essentially, the amino acid sequence is the same, but it is shaped differently. In the case of genetic prion disease, what happens, we think, is that there's a mutation in the prion protein gene. So it's not quite folded the same way as the normal prion protein, but it's also not quite folded the way that a disease-causing prion protein is. Instead, it's probably somewhere in the middle. It's just not completely normal, but not enough to be disease-causing. However, over time, it may be more likely to change shape into that disease-causing form of prion protein. This is another depiction of the prion protein gene. It's made of 253 amino acids, and those numbers are basically the position of the amino acid on the protein. So for example, 135 is basically position 135 of 253 amino acids in the prion protein gene. And you'll see in the red on the top are what we call pathogenic mutations. These are genetic variations that we know cause the disease. And they're demarcated by two letters with a number in between the two letters. And what that basically means is that, for example, in the case of E200K, the amino acid that's coded for the letter E is actually changed to the amino acid coded for the letter K at position 200 of the prion protein gene. That's actually the amino acid that's being changed in that scenario, very similar to the earlier description that I had. So as you can see, there are a lot of different pathogenic mutations that cause the disease. There's probably about 50 or 60. And you'll see in the green on the bottom are what we call polymorphisms. Now, polymorphisms are genetic alterations or variations, but they're distributed throughout the normal population, meaning that some people have this copy, some people have that copy, but importantly, it's not known to actually cause disease. Sometimes it may slightly increase someone's risk of developing the disease, or very importantly, in the field of prion disease, it may actually change the way the illness looks clinically or neuropathologically, but it's not actually causing the disease. So in our field, we care very much about position 129 or codon 129, which has a profound effect on sometimes the risk of acquiring prion disease, especially through transmissible means, but it also can modulate what the illness looks like once someone is ill. So hopefully we have a basic understanding of genetics. Let's talk a little bit more about the genetic prion diseases themselves. So genetic prion diseases as a group make up about 10% of all prion diseases in the US. 90% are sporadic, meaning that there's no known cause, but they're definitely not due to a genetic mutation. They have different names based on what they look like clinically and also underneath the microscope. So for example, there's genetic CJD, fatal familial insomnia, and Gerstmann-Straussler-Scheinker syndrome. And we'll talk about each of those in detail later on. And what's important to know is that oftentimes we do group these diseases and mutations together because they do have commonalities. But it's important to remember that there's also a lot of variability in between all of these. So although we may group a mutation as a genetic CJD or FFI mutation, sometimes it may actually look like the other. So a lot of variability, and just keep that in mind. Now, most of these genetic mutations are what we call point mutations. That was the example that I showed you earlier, where one amino acid is substituted for another, and that's the mutation. But sometimes you can actually have addition of genetic information, what we call repeat insertions, that can cause mutations, or you can delete out information, and that can also cause a genetic mutation that can cause the disease. What's important to know is that all genetic prion diseases are due to an autosomal dominant mutation, with one exception. So autosomal dominant means that it's inherited on one of the non-sex chromosomes, and dominant means that you only need one copy in order to potentially develop the disease. This is in contrast to autosomal recessive, where you would need two copies. The one exception to the autosomal dominant rule is actually an autosomal recessive mutation that was just discovered in the last year. The likelihood of there being other autosomal recessive or many other autosomal recessive causes of genetic prion disease are pretty unlikely at this point in time. But for the vast majority of instances, again, 99%, they're autosomal dominant. So genetic CJD is by far the most common genetic prion disease. It's caused by many different mutations and mutation types. It can be caused by the point mutations or insertions or deletions. And the most common mutation worldwide is one for genetic CJD. It's also the most common mutation in the USA, and that's called E200K. It actually makes up about 60% of all our genetic prion diseases in our country. And as you would probably guess from its name, it very closely resembles sporadic CJD. It looks like it clinically, neuropathologically, and a lot of the diagnostic tests that we use to diagnose sporadic CJD will also be positive in genetic CJD. Gerstmann-Straussler-Scheinker Syndrome, or GSS, is a very unusual prion disease in that it often does not mimic what most people would think of clinically as a prion disease. So it's caused by several different mutations and types of mutations. So several different point mutations, but also some of that higher repeat numbers that we see with the additions that I described earlier, what we call octopeptide repeat insertions, can also look like GSS. And many times they start with isolated neurologic symptoms, such as imbalance in coordination, or maybe Parkinson's-like symptoms. And sometimes people will have these symptoms for quite some time, sometimes years, before they develop anything else. In fact, GSS is often a longer duration prion disease, and that can lead to its misdiagnosis. The average duration for GSS is about 5 years, but there have been cases that have lived for 10 or more, sometimes even 20. So as you can see, it's probably difficult to diagnose because it doesn't look like the other prion diseases. The typical prion disease symptoms that we see with genetic CJD and sporadic CJD, such as memory problems or jerkiness, what we call myoclonus, they do occur in GSS sometimes, but usually not until late in the disease course, and that can throw clinicians off. And a lot of the diagnostic tests that we use to diagnose sporadic CJD will be negative in GSS. So that includes looking at the brain waves and the brain MRI, and we generally don't find suggestive patterns that we would see in other prion diseases. RT-QuIC, which is a very specialized test that's done on spinal fluid, is positive in about 90% of all sporadic CJD, but it's not as sensitive for GSS. Only about 2/3 of cases will be positive. So it probably is, aside from, of course, genetic testing, the most helpful clinical diagnostic test, but in isolation, it will miss about 1/3 of cases. Fatal familial insomnia is a very specific mutation that's coupled to that 129 polymorphism. So if the 129 polymorphism is M or methionine on the same part of the gene that's mutated, then generally it will look like FFI. If instead it's 129V on the same side as the mutation, then sometimes it looks like genetic CJD. And again, there's a lot of variation and it's not cut and dry, but basically that's kind of the pattern that we see. And in FFI, the area of the brain called the thalamus is primarily affected. In neurology, we think of the thalamus as the relay station because so many neurons go through that area of the brain conveying information from other parts of the brain. So a lot of the symptoms that we see with FFI are because of that thalamus part of the brain being affected. So a lot of the initial symptoms include things like sleep disturbances, psychiatric symptoms, and something called autonomic instability, which basically means that you can have a lot of variability in blood pressure, pulse, even sometimes temperature. And like GSS, you can get typical prion disease symptoms like dementia and myoclonus, but they typically don't occur until later in the disease course. It also tends to be a slightly longer duration than what we see with sporadic and genetic CJD, with most patients living over a year. And very rarely are any of our typical diagnostic tests positive in FFI as they would be in other prion diseases. So EEGs, MRI, the spinal fluid tests, they're usually not suggestive prion disease in FFI. Of course, the best way to diagnose it is genetic testing, but sometimes you need to have a clue to do the genetic testing. So there can be some other clinical diagnostic tests that might be helpful in getting that clue. That includes a sleep study or brain PET or SPECT scan. So, for example, for the PET scan, it looks at the way the brain metabolizes sugar or glucose, and that's kind of a proxy for how active that area of the brain is. So in the top image, you see a normal brain. The warm colors, the red, are good. That means good activity. The light colors, the yellows and the greens, are less activity. So you will see in the bottom picture of the PET scan with FFI, the arrows are pointing to the thalamus, which has what we call hypometabolism or decreased activity of that brain region, as what we would see in FFI. So hopefully you understand some of the basics of the three main kind of categories of genetic prion disease. with the recognition that there is a lot of variability and overlap between them. So now I want to touch on just a couple specific issues related to genetic prion diseases that I find important, although there are many others that I'm not mentioning. First off, genetic counseling is crucial. It is key, and we cannot recommend it enough, especially for people that are being tested to see whether or not they carry the mutation and they're not symptomatic of the illness. It allows you to understand all implications of testing, and it helps you to role play the possible scenarios prior to them happening. Believe it or not, it can be very helpful to try to understand how you would feel if you actually test negative, but a sibling tests positive. There's something called survivor guilt that if you can at least go through that as a role play setting in your mind, it can be really helpful if you find yourself in that situation after test results come back. It also encourages you to think about and discuss the process. Even though I understand prion diseases and I understand genetics, I actually would still undergo genetic counseling if I were being tested for a prion disease mutation, because I find that there's a lot of utility in speaking to someone else and hearing someone else's perspective on the disease. It helps you to think about things that maybe you would never have thought of. It also ensures that you're covering all your financial bases at the right time. So oftentimes genetic counselors will recommend that people purchase life insurance or long-term care insurance before they get their testing results. It ensures that you're psychologically healthy and that it's the right time for you to receive the results, but also they need to determine whether or not the patient is symptomatic of prion disease. So it's not uncommon, especially in other neurodegenerative illnesses, for people to actually seek out genetic testing because maybe they're having subtle symptoms of the illness. Genetic counseling can also help you educate about specific aspects of the disease and, very importantly, about the specific mutation that's being tested for. And we'll talk about that later. With that comes a very important understanding of how you evaluate risk, personal risk tolerance, and also personal tolerance of the unknown. Now, what's interesting is that can be very different between individuals, but it also can be different within an individual depending on what domain you're talking about. So someone's personal risk tolerance or tolerance of the unknown could be quite different for financial situations compared to healthcare situations. And the genetic counselor can be very helpful in walking you through that process. And that can be very important when we start talking about something called penetrance. So in genetics, penetrance is the likelihood that someone will develop the illness if they carry the mutation. It used to be thought that genetic mutations that cause prion disease were 100% penetrant, meaning that if you had the mutation, you were going to develop the disease. However, very important work done by Minical and colleagues showed that that's not the case. Although many genetic prion disease mutations have very high penetrance, approaching 100%, there are some that actually have fairly low penetrance. So for example, V210I has a penetrance of about 10%. V180I has a penetrance of about 1%. And as you would expect, if the penetrance is low, there's probably not going to be many other family members affected by the illness because the likelihood that they would have developed the illness are going to be low. This is a very important paper. Eric and Sonia have done a tremendous amount for the field, but I look at this paper at least once a week to help educate family members and genetic counselors on penetrance levels for mutations. And it really has personally affected many family members. We're really at a great gratitude for the work that they've done for this. And really that calls into question this 50-50, right? When you ask someone, well, what is your risk of inheriting prion disease or getting prion disease? We use the 50-50. And in a sense, that's true. But in a sense, it might be wrong too, depending on the individual and the mutation that we're talking about. So for example, if we have someone who has prion disease, they get tested to see whether or not they have the mutation, whether it be at autopsy or through genetic testing while they're still living. They find a mutation, they know what mutation it is. When we counsel the children, we know that they have a 50% risk of inheriting the mutation from their loved one, right? They can either inherit the mutation or not the mutation, 50-50 chance. But depending on the mutation, you have to calculate the mutation's penetrance level. So for example, is it like FFI where the penetrance is almost 100%? Or is it like that other mutation, V210I, where the penetrance is 10%? That's important to know. So then that first degree relative that knows that they're at risk, they get tested. They're negative. And if they're negative, then there's no risk for their children, right? It's done. You don't have to worry about it anymore going forward. However, if that first degree relative gets tested and they're positive, then their children would also have to go through the same calculation, basically. They could decide whether or not, when they're of legal age, adult age, whether or not they want to be tested. They would also have to go through this 50-50 risk and the penetrance and all that. Now, I bring that up because we see this oftentimes in clinic, and it's really important to consider, especially if you belong to a family. I'm going to go through a couple of different mutations and individual choice scenarios that I've seen that I think might be helpful for other family members. So say we have a symptomatic individual who they identified the FFI mutation, and their family is trying to decide whether or not they want to get tested. And in this circumstance, we're talking about children of this individual. So again, the children have a 50-50 risk of inheriting the mutation. We know that the penetrance level for the FFI mutation is almost 100%. So really the risk is 50-50, right? Because either you don't inherit the mutation or you inherit the mutation with close to 100% likelihood of developing the disease. So that first degree relative decides to get tested. Again, if they are negative, their children would not be at risk. If they are positive, then their children would have to go through the same process again. Now contrast that to a different mutation. So we have another person who had prion disease. They got tested and they were found to have the V180I mutation. And their children come into clinic wanting to be tested to see whether or not they carry the mutation. They go into genetic counseling. Of course, you go through the 50% chance of inheriting the mutation, but then you start looking at the penetrance of that mutation. The penetrance of the V180I mutation is only about 1%. So it really is not a 50-50% chance. You have the 50-50% chance of inheriting the mutation, but if you inherit the mutation, you only have about a 1% chance of developing illness. So before you get tested, your likelihood of getting ill is under 1%. So what are you really learning if you get tested, right? Because if you get tested, whether it be V180I that has a penetrance of 1%, or V210I, which has a penetrance of 10%, even if you're found to carry the mutation, you still have a greater likelihood of not developing the disease than developing it as a mutation carrier. So in the instance of this individual decided not to get tested because they did not feel that it was giving them enough information, that it was worth them to actually receive that information. Again, it's a very personal decision. It's going to be different between individuals. And this is why genetic counseling can be helpful, because again, they're going to help you debate on what your risk tolerance is. And importantly, for these type of mutations, how are you going to handle that unknown factor, right? So yes, you know they carry the mutation, but you still have a higher likelihood of not developing the illness. How are you going to deal with that? So one reason why people want to get tested is because they want to have biologic children, but they want to make sure that their children do not carry the mutation. And you can do this through something called pre-implantation genetic diagnosis using in vitro fertilization. Essentially, you do IVF, they make the embryos, and you test the embryos. You only implant the embryos that do not have the mutation. And this essentially eliminates the disease from successive generations. So it's very empowering. You can even do this if the patient or the parent does not want to know their genetic status, right? They know they're at risk because their loved one had genetic prion disease. They themselves do not want to know whether or not they carry the mutation. You can still do this. And I would encourage you to read the very good book, Mercies in Disguise, which is about one of our genetic prion disease families. And they do talk about PGD with IVF in that book. So if you learn nothing from this talk, as always, know that there are a lot of people out there for you. There's the CJD Foundation, there's the Prion Center, there's the genetic counselors. And whereas there's not a whole lot of genetic counselors that have experience with prion disease, we certainly can help arm them with the resources and the knowledge that they need to make sure that you're making the right educated choice for you. So as always, thank you for all that you do for the CJD Foundation, for the Prion Surveillance Center, and for each other. Thank you.